Morning, everybody. I will say I'm filling in for Peggy today, and I'm a poor substitute, but I'm delighted to be here with everybody today. And if you're just joining, I will ask you to please put your email down in the chat box or any questions that you may have in the chat box so we can get those with Catherine. Lots of times we find out that questions get answered later in a presentation, so we don't want to double back on it. But if you do have a question at the end that we haven't addressed, please just raise your hand and we'll go from there. Again, Happy New Year to everybody. And I'm going to go ahead and introduce Catherine. We are delighted to have Catherine Plunkett with us today. She is a very experienced quality improvement professional and healthcare consultant. She has a long track record of driving transformative changes in the healthcare system. She's been doing this, and she's so much younger than me, so it just kills me when I have to say this. She's been doing this for over decades, but she has, and she has a lot of hands-on experience in the clinical quality improvement, technical assistance, healthcare programs management, and she uses generally the Lean Six Sigma methodologies, data-driven strategies, and evidence-based practices to enhance healthcare delivery and patient outcomes. And that's what we're all about. We want to do what's best for our patients, our residents, our clients, whatever you may want to call your group of people, our agencies. And we are also looking into expanding this further along during the year and hoping that we can invite some more people in. I'm going to ask you if you have anybody that you know would be interested in joining our quality leader sessions to drop either me or Peggy a note and let us know. And now I'm going to turn off my camera and turn it over to Catherine.
Hi, everyone. I'm happy to have you all today, kicking off the new year with our quality leader session, and we're going to focus on just some of the basics, the PDSA cycle, and how to use it in your QAPI plan. Jewel gave me a great introduction, so I'm going to skip over this just to kind of look at what we're going to do today. The roadmap, we'll start with some quality improvement overview with QAPI, and then go into just the purpose of the PDSA cycle, break it down in some fun examples, one fun, one serious. So learning outcomes, discuss how the PDSA works in your QAPI plan, discuss the steps of the PDSA, and then list the steps and discuss, like I said, the fun examples. And I'd love to open it up at the end just to see if anyone has any questions or has examples of real life lived experience of how they've used the PDSA assessment. So a PDSA is a tool that you could use as the engine of a QAPI. It's the primary method that to turn issues into structured, measurable improvement. And it can, if used consistently, provide a good way to address quality concerns as they come up, and have it be the tool that you use to respond to issues. It's healthcare is such a moving target. There's always going to be something coming up, always something new. So to have your team really experience into using the PDSA as a way to address any concerns that come up, whether it be for survey finding or an adverse event, will help ensure that you're really addressing it in the right way. And again, I mentioned the safety and quality issues, survey citations, adverse events, incident reports, quality measure trends and data dashboards, staff and resident feedback. It's a way to focus and test solutions to these issues rather than assigning blame, and to really work small and then build out over time to address the systemic issues as well, if there are any. And it can be deployed rapidly. And I think that's important to note that this tool can be used next day. You can start implementing this. We talk about something in a QAPI meeting, let's start a PDSA cycle, and it can be done same day. It's not something that has to be thought out. If your staff are experiencing this, you've had some just basic QI trainings and are familiar with this, you can deploy this on demand as things come up in QAPI meetings and for your overall organizational quality plans. It just needs to be part of the culture in order for it to work for QAPI plans. The quality just has to be part of the culture. It has to be the way we respond to things. Make it part of routine operations. And I can't emphasize that enough in your QAPI meetings. And overall, if you adopt this tool or are currently using it, just to make it how you respond in department meetings and shift reports, and embed it into that. And make sure that all the staff who participate in QAPI, and even when they don't participate in those meetings, to understand in shift reports and whatnot, important announcements and updates on them, I think is important as well, even for those who aren't directly the ones leading it. It increases staff buy-in and problem solving, and it really isn't meant to add to the work. It's really just meant to document work, the PDSA cycle for your QAPI plan. And who you're going to involve, definitely their frontline staff, definitely your frontline staff. Again, even if they aren't formal attendees of any sort of quality meetings, to stop and pause and get their insight, especially for nursing assistants and nursing homes. So important. They're the ones who are going to typically be enacting the changes. So to get their opinion and make sure you're validating experience and validating what they think the problem is, in addition to what has been reported to you. Increases adherence to change to engage them. So when you gauge them in the process, they're more likely to stick to the solutioning and support the overall goals of improvement. And you want to track improvement across strategic goals. Sometimes in healthcare, we just have to pivot. We just have to pivot. Things come up and we thought we had our priorities aligned, and then a survey unannounced, a visit, and we just have to pivot. So, this says not to overload and work on one thing at a time, but we work in healthcare, so sometimes it is what happens. But just to be mindful of the quantity of change and what you're changing overall, to mirror it back to those strategic goals and be intentional as possible in what you're working towards for quality improvement, and then also responding to events as they arrive. But if you really have those QAPI plans, and there's alignment within your organization, the PDSA tool can be aligned to help you achieve those. And then also just linking it back to these things that come up, because this is healthcare. We're always responding to a new fire to put out. What I love about the PDSA cycle is that when you do it regularly, you have a clear documentation of your progress. And so new staff, if you think about all the barriers to change, new staff come in, staff come and go, come into an organization, they leave it. People are out on leave for extended periods of time. People just miss a meeting because they're, like I said, busy putting out another fire. When you use the PDSA tracking tools, it helps you to have that so people can reference back and follow along, whether they're new to the organization, just had to step away from the quality meetings for a little bit. Helps that longevity of the process and helps really institutionalize it as part of the culture, to document it. And all those communication barriers that come up over the little nuanced things can just help alleviate those. So kind of that was the bigger picture of QAPI plans and how the PDSA can help you achieve those. So let's talk about what is the purpose of a PDSA and what does it involve? It's more than just a tool. It tests change, and it's a structured, repeatable method to document and guide a full arc of quality improvement. So we are planning to do something and making instead of rushing into change, we're taking the time to define the problem, set an objective, make a prediction of what we think will happen. Really important in healthcare. In other businesses, maybe they can just enact a new solution overnight. In healthcare, we have to think about 1,000 different regulations we have to meet at all time. And then we have the bottom line of patient safety and quality care at all times. So to plan out and think through what we're going to do is so critical because it involves patients' lives. So that's the first step plan. Second is to test safely. We don't want to overhaul a whole system overnight. Start small, pick away at a problem and see what works. Study the results and see, did we achieve what we want to achieve? And then finally, act intentionally. whether you're adopting or adapting or abandoning, and then moving on to the next cycle and keeping the PDSA cycle going. Why use it? It encourages small, measurable changes. Again, in healthcare, rarely do we want to just overhaul this whole system, a whole system overnight. We want to work in small, manageable bites at a time to make improvements. It facilitates transparency and team alignment. Again, talking about the documentation and a consistent way of approaching a problem. Everyone's on the same page. Everyone gets the documentation, and people are aligned to the objectives because we're documenting and we're communicating as much as possible. It encourages that culture of continuous improvement because it's a cycle. Plan, do, study, act. PDSA, we're just going over and over again. So it encourages that culture of improvement because the entire PDSA cycle sets you up for the next one and the next one and the next one. It supports real-time learning because we're not waiting on data collection for these intense long-term objectives. We're really working on short-term manageable changes and chunks and working on what we have. It minimizes risk, like I said, because we're testing before scaling. So if you manage 4 different nursing home sites or 4 different sites, we would only want to adopt a new program and test it out on one site before we overhauled all 4 all at once and make sure we've refined this and fine-tuned it as much as possible for a much larger scaling rollout of a change. Again, I mentioned involving frontline staff because it's a way to get them engaged and get buy-in for the initiative. Data-driven decision, and we're going to talk about data in a minute. In quality improvement, we need data to make informed decisions. I feel like sometimes the people who love data have a tendency to over-measure. We're going to measure all the things and look at everything we could. People who hate data really don't want to look at it. It's got to be somewhere in the middle. We need enough data to make informed decisions, but at some point, too much data just slows it down and really isn't achieving the purpose. So it's somewhere in the middle of those 2 people. You have staff who love data and hate data, and it's somewhere in the middle is what really helps drive that decision making, is just enough data to make informed decisions and enact them and adopt them across sites, but not so much that we're just getting so overburdened and slowing it down by we could measure everything. Should we? Is another question, right? And the goal is we're enhancing patient outcomes and operational efficiency. That is truly just the overarching goal of the PDSA cycle. And I always like to put this in there. You are already doing this to a certain degree. And I have this silly little example at the end that I hope on some level people connect with. You already do this every day. You do. You might not do it formally. You might not be in a forum. It might not be with a committee meeting. But in your personal and professional life, you are likely already have a quality mindset where you're trying to improve. And all a PDSA does, because people get so, caught up on the new tool, we got to do this, is streamlining that process that you're already doing. So every time you tweak a workflow with your staff, you're trying something new, you are testing change. Everyone does that every day. And what we're trying to do with the PDSA cycle is formalize that, eliminate communication issues by getting everyone on the same page with the method and the documentation, and kind of working from there. So we're going to go over each step in a second, but you're already doing this, just not formally. And it's a mentality, right, of continuous quality improvement. And all we're doing is streamlining that so all your staff are on the same page. Plan, do, study, act. Plan, do, study, act. This cycle. We're testing change. We fill out 1 worksheet per test. And again, I think it's really important to emphasize the need to document. It could be paper. Your facility could do it digitally. Whatever works best for your team, wouldn't get too caught up on that. But that documentation helps people when a new staff member, you're onboarding them. Part of their onboarding process, we did 5 cycles of test change to reduce or to improve documentation around wound care. We want you to read through every one. And then we'll talk about what our current practice is and how we've adapted over time. So you could use those documentations to onboard staff, in addition to just getting the current staff at the time you're testing all on the same page. Digital, what template you use, a dozen different templates, whatever works best for you and your facility. But that having that documented is so important, and you can use that in so many different ways, like onboarding new staff. Something comes up, you backslide, you go through a staffing crisis. The flu season, my goodness, is upon us. I think some facilities are coming out the other end of it, but it is still a problem. Very prevalent, at least in the area I'm in. And January rolls around, February, we're finally coming out of the flu season and COVID season and the crud season, and you need to dust it off and pick it back up. Your PDSA cycles, having that documented is so important because it helps that. It helps the real life aspect of it, of just some weeks you took care of all your patients and that's all you could do because there are staffing crises with everyone's out with the flu. Again, data-driven, flexible, and you're engaging the whole team. So I've mentioned all those previously. So step one is plan. This is where you want to pause and just try and be thoughtful, look at the problem. We don't want to be reactionary. We want to really think about what are our objectives. So we have a problem with, wound care documentation, or, insert any kind of customer service problem. Root cause, what do we think our objectives are to improve, and how do you want to tackle it? Imagine you're standing at a trailhead of a hike and you don't know even what direction to start walking in. Pause, look at a map, decide which path to take, think about how long it'll get there, the supplies you have, and then make a decision. And that's what quality improvement is. That doesn't have to expand over multiple meetings. We don't need meetings and meetings. You can achieve that in one really cohesive meeting, but we do want to stop and just be intentional. To start by defining the issue. That's the first part of the P in PDSA. Define your objectives, what you're going to measure. It could be patient complaints, family complaints, documentation issues, and then the who, what, when, where, why, and like I said, metrics. We can't measure it all. What metrics matter for our objective, and having that really clear lens, because there's people like me who love the data, who want to measure all the things, people who hate it. We need to get somewhere in the middle where we can just achieve what we want to achieve for this test. Do we want to implement on a small scale? This can look, what a small scale is defined as is going to look different across every single organization. If you're managing 4 or 5 different facilities, maybe you just pick one. Maybe you pick one unit of a facility. Sometimes the patient population you're testing this on is so small, it's all or nothing. There's no way to kind of parse it out. It's just implementing. That's okay too. But just think through what your facility is and what your, scope of the project is when you're starting small, and ensure communication. Today's the day we're documenting this new template we're going to use. Make sure everyone knows. There's signs, there's posters, there's email reminders, however works best for your facility to make sure everyone's on the same page. We want to get that communication in place during and in advance of rollout, just to make sure we're testing in the most safe and controlled way. Everyone involved needs to know what's happening in order to run smoothly. And just as important, take notes along the way about what worked, what didn't work, what challenges popped up, what surprised you. And of course, when you're implementing, start collecting data. And again, the data is whatever is relevant to measuring your objective. So it's going to look different in every scenario. Third step is to study. And this is where we try and really learn from our actions. Stop. So you implemented for a week, 3 weeks, whatever makes sense for your project. And stop and say, did we achieve what we wanted to achieve? Did things go as predicted? It's a bit like checking the scoreboard after a game. You want to see if the play you tried actually worked. Sometimes the numbers confirm your hunches. Other times it tells you something completely different, and that's okay. time to reflect on the lessons learned, what worked, what didn't. Were there any unintended side effects? That's important. I don't know if anyone works in a hospital setting, but the classic one that everyone references is length of stay versus readmission rate. Those typically are like the balance is you improve one and it makes the other one tank. So you improve to get your length of stay down in a hospital. And as a result, it's very frequent to have your readmission rate, 30-day readmission rate creep up. Whatever you're working on, you just want to make sure we're thinking those kind of things through. We're working with real live patients. And other, you hear about PDSA cycles and like manufacturing. They don't have there is nothing like healthcare. They don't have the lives on the line like we do. So it's just something to be mindful of. It might not be relevant in every situation, but just to be mindful of. And studying just gives you the evidence you need to make an informed decision instead of just going with your gut. And listen, some of y'all have worked worked in your field for long enough. Your gut's frequently right, but we just need to validate that instead of just making a decision off of hunches. And the first step is to act. You could sum up the act with adopt, adapt, abandoned. 3 words. We're either saying we achieved exactly what we want to achieve. We're adopting it to implement on a larger scale. We need to adapt it, tweak it, and retest, tweak, retest. Or sometimes it's just like this just didn't go any way we wanted to go. We're abandoning this process and getting a whole new one. All valid responses. But really, when you go to the A part of the PDSA, you are picking one of these, adopt, adapt, abandoned. And then immediately start moving to the next PDSA cycle. So in your COAPI meetings, you're saying this data was great. We still only have a 70% compliance rate with staff documenting this. We really need to get it higher. What else can we do? So that would be adapt. We need to run a new test to try and increase compliance with documentation and just keep on going until we hit our goal, which might be 100. It might just be, whatever internal goal you have that's relevant for what you're testing. So here's my little silly example of a PDSA cycle inspired by my son, who's a very picky eater, creating a peanut butter and jelly sandwich in the ideal shape is my goal. I get feedback on the shape of the sandwich. I get feedback on the taste of the sandwich. I get feedback on the texture of the sandwich. And how am I measuring this? I'm measuring it by the number of complaints and do I have at least a decent, I don't need a clean plate club, but I need like enough nutrition to be eaten that he's going to sleep through the night. You know what I mean? So my aim is just to create a high quality peanut butter sandwich for a child. And everyone, insert whatever grandson, niece, nephew, like whatever. Every kid goes through this phase where it's like, and my husband makes it, and it's like, that's not the way mommy makes it. So also you could add in here, it's the person making it also matters as just watching mom make it sometimes matters. So whatever silly example you can think of in your head that's relevant, I'm going to walk through a peanut butter and jelly sandwich because also it's cheap and easy to make, which matters to mom. I'm not trying to like make this gourmet meal be this meal. So there's a lot of units of measurement that are involved in why I selected peanut butter and jelly sandwiches. The ones that matter that I'm going to track are just the number of complaints, triangles, squares, shapes, and just was it eaten? That's really all I care about. I just want enough food in his stomach so he sleeps through the night some nights. You know what I mean? So this is our goal for our PDSA cycle. First up, we're focusing on consistency. Needs to fit in the lunchbox. It needs to be visually appealing to look correct, So I made it with white bread. I wish he would eat like a whole wheat, something with a little more iron in it. I'm just giving that up. Creamy peanut butter and grape jelly and a circular cutter, to make a round, consistent shape. He ate it. There's zero shape or crust complaints. Circle's a good shape for him. But it was really soggy and didn't look right, you know? So we are adopting the round cutter for the shape of the sandwich. We're adopting that because that worked well. We need to improve like the texture and the taste though. So we're adopting one part of this method and we are going to adapt the taste part. So, I test again next week, whenever. We're going to use more kid-friendly ingredients. So we're adopting the round shape cutter, but we're going to make it with honey roasted peanut butter and strawberry. Got some feedback about the grapes, so we're going to try strawberry out. And my goal is just, again, I don't need a clean plate, just need enough eaten, enough nutrition ingested by my toddler. Big improvement, love the strawberry, big strawberry grape guy. This is the study part. So I've spent a week making peanut butter and strawberry jam sandwiches. Love the flavor, love the jelly. Still like really messy. I'm having to wipe him up. I get feedback about like, he's a guy who like, because we're tracking the number of complaints, right? He doesn't like messy hands, which is shocking for a toddler, right? So it was too soggy and the jelly got on his hands, but still great shape. So we are keeping the circular shape. We are keeping the strawberry, but messy hands. He's like the only toddler you ever made who's like really particular about things. So no, doesn't like that it's gotten on his hands. It's too soggy. So now we're reviewing this data, we're acting. We're keeping the flavor combo, we're keeping the round shape, and now I just need to figure out, because I have so much free time to think about peanut butter jam, peanut butter and jelly sandwiches too. We're working on sogginess and texture issues. And so I achieved my goal eventually. We reduced sogginess, maintaining taste because we adopted the round shape, we adopted the improved ingredients, and then I changed up how I did it. So bread, peanut butter, jelly, peanut butter, bread. So like the jelly is not sitting on the bread. There's like a peanut butter enclosure between the jelly and the bread. And that achieved it. So the peanut butter barrier technique, another mom friend told me about this. It has been, I'm really thankful I get my son to just eat the most simple sandwich now. So great. I only measured, I mentioned some other things I could have measured, like cost. This is a very cheap thing to prepare my son. It's decently healthy. I only cared about at this moment in time in my life, was it eaten? And did I hear a lot about it? Was there a lot of complaints? I achieved those two things. So excellent. Maybe one day we'll work on converting to like a whole wheat, really healthier bread. You got to pick and choose your battles. So there's more we could have measured. Pick and choose your battles, right? I achieved my objectives with this. So this isn't my son. This is like a stock photo, but yes, thumbs up. Okay. So this is a ridiculous example, right? But I hope y'all realize that you do this in your life. And all we're doing with the PDSA cycle, insert like your toddler, insert I don't know, your husband, you need to train him. I don't know. You're doing this in your life. And all we're doing in healthcare is documenting it. The stakes are much higher. We're documenting it. We're thinking about outcomes. And the PDSA cycle is just a way to formalize what you already do. So don't get caught up on the terms. This is what I tell people if you're going to start this at your facility for the first time. Don't get caught up on the terms. Don't get weighed down by logistics. You're already doing this. It's a way to document and communicate it and constantly have that culture of improvement and use this tool as it. So, okay. In primary care, example, this is we're going to go with for primary care. If someone has a high blood pressure reading, evidence-based practice is that you need to wait a minute, it's not like really a minute, but wait and then remeasure. White coat syndrome, insert just, insert just a COPDer who had to walk from the lobby to the scale, to the waiting room, answer a bunch of questions, they're out of breath. Sometimes that matters, so if you get this high reading, wait and remeasure. that's a problem in healthcare. They take one measurement and then that's the measurement. So high quality hypertension management is repeat blood pressure measurement for patients whose initial reading is over 140 over 90. And so this practice had a rate of repeat measurements at 42%, and we want to achieve 80 by the end of the year. This is a dated PowerPoint, so sorry I didn't catch that. It's 2026. We're changing that year to 2026, new year. We're only, again, we could pick 1,000 different things to measure. What do we need to achieve this? We need to know one reading, the percentage of patients who have a repeat measurement after the initial reading. We could measure 1,000 different things with processes and this and that. This is our objective. Keep it simple. So we're going to put visual reminders in the exam rooms. That's the first thing. We're in a copy meeting. The nurses are saying, the medical assistants know this. It's just they're doing 1,000 different things, and it's one of the 1,000 things they need to do, and it just gets forgotten. Fair, right? So the nursing directors are talking. We need visual reminders. Let's test that out first with our staff. And our prediction is that visual reminder will increase compliance with blood pressure measurement procedures. So we put visual reminders in the exam rooms for 3 weeks, excuse me. Staff are informed that the test is mentioned at the beginning of every huddle, and then we're tracking that one measure. We just want to see repeat blood pressure documentation. So we test it. 3 weeks later, we pull the data. We've had a 6% increase in repeat blood pressure documentation. So we've seen an increase. It's not enough, though. So the nurses are talking with the medical assistants. What happened? What can we improve upon? And they get feedback. Their visual reminders were great, but they were put in really high traffic areas and blended in with the environment. And is there a way to help remember? Because again, no one gets into healthcare. There's no blame or shame. Wanting to do bad, like wanting to perform poorly. In primary care, the weight of so much quality improvement is put on medical assistants to measure, to put in all this stuff. So just how can we, of the 1,000 things they've got to do, depression screenings, I mean, the list goes on in primary care. What can we do to help them, to cue them, to get this on the forefront? So we're going to adapt the visual reminder. Bold, it's large now, large. It's everywhere. It's not in the high traffic areas. We put it directly on the blood pressure measurement cuff, and we're tracking that. So we had already increased it from 42 to 48. This cycle, it jumped up to 69%. So that's awesome, but we're still not achieving our goal. We're getting a lot better though. So staff said that it was great. They liked where it was located. They liked it. It really helped them remember. It helped them remember the repeat number too, 140 over 90, when to cue them to remeasure. But it's not where we want. So the nurses get together in the coffee meeting and we say, handoffs have always been a weakness. Let's see what we can add to the handoff. And so the next step, the next PDSA cycle, we're going to work on handoffs. We're adopting the signage, we're testing something new. So we're going to improve handoff communication between medical assistants and testing a new step in the workflow where the medical assistant verbally reminds the provider, hey, they need a repeat blood pressure measurement, because some providers prefer to do the repeat measurement themselves. There's 1,000 different scenarios that might be particular to your practice. So we're just working on verbal handoffs. The repeat measurement is needed. So we're predicting that this will finally get us to our goal, and it did. So we've adopted the visual reminder for 2 weeks. The medical assistants did that verbal check when the handoff to the patient, they need a repeat check. Data was tracked and we met our goal. We're at 82%. So everyone's happy. And both of those are adopted. So my silly example of peanut butter and jelly sandwiches versus work examples, low stakes versus high stakes in healthcare. Again, that doesn't speak to that you don't already do quality improvement. It just speaks to the fact that we need to document it. We need to get good communication around testing change. What are the like, okay, my son doesn't eats like half of his dinner. The stakes are kind of low. Stakes are high in healthcare. We're measuring improvement. We're working across multiple sites, multiple teams, working across shifts. We're working across, types of staff, medical assistants, nurses, doctors. It's way more complex. Healthcare requires more data collection, more reporting, all formalized by CMS, by other, third-party entities. Um, and so when you think about why we have to implement things like the PDSA, it's to meet the needs of our work environments. We already have this culture in our personal lives. We already are doing this, but it helps us meet the needs and demands of our workplace to document this, to get the communication in place in the QAPI meetings, to really formalize this quality improvement. So if you ever get bogged down, just think about something you've done for your family, for your kids, where you've kind of just tweaked and tweaked and tweaked until you got the result you wanted. Um, Everything you work on in healthcare is the exact same. It's just we're using formal documentation and communications. I'll pause there. That's all I've got. And we will open it up to questions and see if anyone has any thoughts, questions, comments.
I don't see any direct questions in the chat box, but remember she said she wanted to hear some improvement. I just wanted, or some feedback, not improvement. She did a great job. I just want to say you could fix me a peanut butter and jelly sandwich anytime you wanted, and I promise, even if it was on whole wheat, I would eat it.
Thank you, Joel.
Oh, always. This was an excellent presentation, and bringing in the personal side of it really hit me at home, because I think we all think about doing a checkbox, making sure we've done this. So to know that we do this every day in a different way, and yes, healthcare is different, but okay. So anybody, any questions before we close out? I would love to hear some of y'all's thoughts on this.
Thank you, Catherine. That was a fantastic presentation. Um, I just loved how you walked us through how we're already doing these things. To Jewel and Catherine, how do you think that we can incorporate some of these skills that we do on a routine basis? How do we take credit for that in QAPI?
I would say documentation and communication. Your medical assistants might already be doing this independently of your QAPI meetings, where they position supplies to help support this and this and this. And, you get a good idea like that. And how do you standardize it? How you get credit for it is just good communication and good record keeping too. You can backslide so easily in healthcare with some bad staff turnover. I keep on mentioning the flu season. Y'all are in the thick, we're all in the thick of it right now. It's really easy to backslide to get credit, and then like you lose it. You lose that improvement. So I would say good communication and good documentation. In the moment when you're filling out another PDSA form, you're like, why? Why? And then you have a staff turnover event, and that's the why, helps maintain the momentum and help maintain the improvements.
And I'm going to say too, involving other people that in your QAPI that you may not have thought about. We all know that we have to have, this person, this person, this person, and this person. But it's all the workers out there that are doing this in our healthcare systems the same way all of our family members are doing it personally. So, get the input of people, even if they don't want to join the formal meeting. Make sure we have communicated with the people that are actually boots on the ground doing some of this, and take credit for that, or, and recognize them. Everybody likes to be recognized for the fact that they're doing what they need to be doing. And sometimes we forget about that as our staff as leaders, as our staff goes down, but it takes that village. And we just need to make sure that we incorporate those people either in the meeting or at least give them some credit for what they're doing already.
Well, thank you all so much for having me. I can make sure we send out the presentation and get that sent out. We can do that, right, Jewel?
Yes, ma'am. Yes,
Let me
ma'am. I
double
had to
check
come off
before
the
I
mute
commit.
again. Yes, ma'am. We certainly can.
Okay.
And
And
again,
then
thank you
y'all all.
so much. No, thank you. I do want to, before we close out, I do want to say that next month will be on February the 19th. It's always the third Thursday at 11, unless something changes. And we're going to have Christiane Harden come in. And this is going to be another one of those great presentations for me, coming from the long-term care world, but it really applies in our personal life as well. My mother's 92 years old, so I can see, where this would apply directly into my personal life. His presentation is going to be, it's not dementia. So we need to rethink the behavior and cognition in what we see in our residents in long-term care sometimes. So that's going to be another one of those that will hit a lot of us personally as well as professionally. And we can't wait to see that. That'll be at 11 on the 19th, and we'll send out reminders again before then, because sometimes if y'all are like me, even if I have something on my calendar, it's a good little nudge for me to remember something else. Does anyone else have anything that they want to say? Catherine, getting a lot of likes over here and loves in the chat box for your presentation. Like I said, I'm looking forward to my peanut butter and jelly sandwich. Anybody else? Alyssa, do you have anything that you want to say before we close out? And thank you so much, everybody, for coming in and going through our little cancel, start as we're working through our process of getting this done.
No, agreed, Jewel. Thank you all. It's so nice to be kicking off the new year with everybody. We've got an exciting year ahead of us, and as always, we do not want to complicate or redo work that's out there. So if there is anything that you're interested in learning about or you think is impactful and you're looking for recommendations or support on that, let us know. We're happy to come in and complement some of the amazing resources we have in the market right now. So just send us an email and we will work on getting a speaker or doing the presentation for you.
And I'm going to ask again if y'all will share this among your staff, among your teams. You never know who you're going to reach sometimes, and emails change. We all know that our workforce changes a lot around us every day. People who were with us may no longer be with us. Please don't hesitate to reach out to us. Say, hey, Jewel, I want to join. Hey, Peggy, I want to join. Hey, Alyssa. Hey, Catherine. Hey, Maxine, I want to be involved in this. We would be delighted to have all of you come in. So please share, if you will. Nothing will be held back from you. We'll make it just as clear and easy for you as we can. Well, I'm going to say goodbye to everybody, and thanks again, Catherine. And you may make me get up and make my own peanut butter and jelly sandwich at lunch now, just thinking about